how we like to see them. So this is the post-processing where you get the right coronary. In this case, this right coronary has nothing calcified. Here is a patient with an LAD, and you see that there is some calcifications, but there is also these non-calcified lesions. And this here is a circumflex. We can catch every of these vesicles nowadays very, very easily. Here you see an LAD, and here you see a circumflex. One thing that you're going to see the more you use these CT scans is this phenomenon. That is an intramural course of the vessel. That is not atherosclerosis, but it's just running within the muscle. This one is completely normal, except that you see a very little spot of calcium there. This is what we get often. So here is some calcium. Here is mixed lesions. Here is a calcium. Here is non-calcified. Here is non-calcified plus calcified. And here is very diffuse calcified spots and non-calcified lesions. If we take a look at this meta-analysis, which was done already in 2008, 64 slice CT, now everybody uses these 320 CT scanners or even bigger. And you see that if your CT scan is completely normal, the rule out of coronary disease as compared with invasive angiography is very, very good. Normal CT scan is almost completely identical as what you will see on the CT as on the invasive angiogram. So 100% rule out is a good one. So if your question is to your patient, this one is presenting with chest pain and you want to rule out the coronary artery disease, you do a CT scan, it's completely normal, then basically you rule out coronary artery disease. A rule out is good, a rule in makes it more difficult. Now we have these 320 slice scanners and even higher, and they are even more precise than the scans that I just showed you. So now what if my CT scan is not negative, but it's positive? What am I going to do? Am I going to revascularize all of those? And if not, who should I then revascularize and how am I going to manage that? So then the question comes, should we look at the hemodynamic significance of a stenosis? This is the conventional CTA. This is the post-processing into a 3D model. And these are the physiological modeling of the coronary circulation. And then comes the computer calculations of fluid dynamics. And then you can measure the FFR based on your CT scan. And I see here in this vessel an FFR of 0.86. This vessel 0.75 and this vessel 0.95. So we go from pure anatomy to functional consequences. Here we compare some with the CT scan and the angiogram. CT stenosis 70 to 80%. The FFR is 0.94. And you see here the FFR on CT is exactly the same, 0.93. So there is a stenosis, 70 to 90%, but it does not affect your FFR. Let's go a little bit further. We go to a symptomatic patient. This patient has high likelihood to have atherosclerosis, and the question is, does he have ischemia? Do I need an intervention? So then we move away, if that is your question, from a CT scan, an anatomical atherosclerosis assessment, and we go to a non-invasive ischemia test. In the ischemia test, we can do anything that we want. We can do the nuclear test, as you see here. This is the stress situation. This is the resting situation. Here is a perfusion defect at stress. Here it is also. There it is also. If I do now the resting situation, you see that the perfusion defect almost disappears. And then you can quantify the extent of the left ventricle that has ischemia. Oh, goes a bit too fast. We can, instead of a nuclear scan, do a stress echo. We do here in this place a lot of stress echoes if we're looking for ischemia. This is the resting situation. This is the 10 micrograms of the butamine. This is the 40 micrograms of the butamine. You see now significant movement of all the areas. And here's the resting situation. I think the downside is that the echo often not gives you such good visualization. So what we do a lot, here is the patient the same as that one. We give this intravenous contrast. Almost always in every patient where we do stress echo, we do the contrast. So we can much better see the wall motion. and the wall thickness. This is what we would like to do in every patient. Here's a resting MRI. Here is 10 micrograms. Here's 20 micrograms. And here's the maximum. This is, of course, much higher resolution than all the techniques I showed you before. But an MRI takes a lot of time. Some of the patients get claustrophobic in the scan. It's interesting to see here that if you stress this patient with the stressors, the pharmacological stress, you see that the patient developed actually a secondary MR. And then we can measure the perfusion. Of course, this is very great material, but this one here shows you that there is endocardial ischemia, and you measure the perfusion defect here. And then when you do the angiogram, you see 3-vessel extensive disease. So MR functional is dobutamine and looking at contraction. MR perfusion is looking at perfusion and scar tissue. Symptomatic patients, detection of coronary artery disease, when to revascularize. Probably if you have a severe stenosis, or if you have not so severe stenosis, it will be ischemia. Asymptomatic patients at elevated risk, what do we do? Screening. I think we can do a lot of that, but we're also bringing ourselves into difficult situation, as I said. Symptomatic, low risk, assess or exclude atherosclerosis. We do a CT scan. In the symptomatic higher risk, here we do immediately ischemia testing. That was all I had to say. Very simple, actually. We work more and more with CT scans, and then we do an ischemia test if we feel that is needed. Sometimes, and that depends completely on the heart team decisions, sometimes we do immediately based on the CT scan, just purely stenosis-driven revascularization. If you look at all the bigger centers, this discussion point of when do we revascularize, do we do stenosis severity or do we do consequences of stenosis, which is ischemia? That question has never been very well answered, and I think that's going to be very difficult. So we stay a little bit in the middle, and we discuss it in the heart team, and based on that, we take our decisions for these patients. Thank you very much.
नासिर सवाल कर लें
जी जी प्लीज
Professor Jeroen, are you there?
Yeah.
Yeah, this is Shahbaz. In patients, when you are doing the calcium score, if it is between 11 and 100 or a little over 100, would that be a criteria for you to start using statins and aspirin in these patients as a preventive
That's a very good question. First of all, it costs a lot of money. Not, of course, if you work with the statins, etc., that are off patent, but still, if we're going to put, and it's almost never that you see CT scans that are completely blank. So you could even question yourself, is this just a way of aging the way we have our lifestyle, what we eat, and the limited exercise often to get a result in these phenomena? And the question is, should we treat all that or not? And so I think this is a very difficult question that you raise. And then also based on just a little bit atherosclerosis and no ischemia, should you revascularize? We do basically the combination between visualization of the stenosis and the ischemia. And then based on that, we discuss in the heart team and we take our decisions. You're asking about then, what about the statins? I think that's a very difficult question because the statins, as I said, have a lot of side effects. A lot of people don't tolerate that well. What the statins do, what we have been seeing in sequential CT scans, is that it mostly calcified the lesions. And so therefore you're not taking the lesions away, but you are sort of changing it from non-calcified to calcified. And we believe that the non-calcified is the pretty dangerous one, and the calcified is also dangerous, but much less dangerous. So therefore, if you give high-dose statin and you calcify them, then it's probably a good thing for the patient. At the same time, all these new drugs that are on the market costing a fortune, and we see now here that we can, in terms of medical costs, we cannot afford that in all these patients.
Can I ask one more question?
It should be brief, sir.
Okay.
Yes, please.
I think this is a very good imaging, the CT, FFR CT and IFR CT, but I guess you have to use plenty of contrast there. How safe do you feel in a 65-year-old, 20-year standing of diabetes with borderline liver creatinine, perhaps slightly elevated? So how do you manage these patients? Do you feel happy putting in so much contrast in them?
No, I don't. I think we of course don't have any randomized controlled trials, so we cannot say so much contrast is good and so much contrast is not good, but we do see that every now and then we have problems with that. So I'm a little bit careful with sending everybody to the CT scan, because if we send all these people with a little bit elevated risk factor to the CT scan, we're going to get back that they're all having atherosclerosis. Then comes the point, how about then the expensive medications? Well, that we cannot afford as the way it's going to develop now. It's just going to be too expensive.
Thank you, Dr. Giron. Thank you very much for your comprehensive talk.
Just one question. Somebody
Yeah,
with
sure.
a calcium score of more than 1,000, asymptomatic, and an imaging stress test is negative.
Yeah.
Would there be any use of repeating the calcium score 2-3 years down the line, or would you like to repeat the imaging stress test as a follow-up?
I think I would do the imaging stress test, because the way I see it is that the real problems with the atherosclerosis are the non-calcified. And that I think is very hard to do repeat scans just purely for that. So we still work very much ischemia driven. So if we see the patient at this time, then later on, usually we do a dobutamine stress echo because it's easier to do and there's no radiation. So we usually reach out to sequential ischemia testing. How do you do it in your practice?
Jeroen,
Imaging stress test.
invariably what I have seen is that if you have a calcium score over 300, 400, and you do a coronary angiography in them, you have coronary artery disease. And if you do a carotid ultrasound, you will find a lot of plaques there. So I think that as the calcium score increases, then you don't do a CT angio, you do a coronary angiography.
Yeah, and if the patient is totally asymptomatic, what are you doing then?
So probably an imaging stress test would be a very nice thing as a follow-up, like a CMR.
Yeah. Yeah, we do basically the same as you do. So the first test is atherosclerosis, then we follow up with the patient, we give medication if needed, we follow up with the patient, and then if there comes chest pain, we do ischemia testing.
Thank you,
I was
Jeroen.
at the
Thank
big
you very much.
meeting not so long ago in Finland, where there was a lot of people available, all speaking about CT and when do you do it and when do you not do it. And there were a lot of people working very advanced in this CT scan business. And I think that it's not clear actually how you should bring all this information together. We simply don't know. Are the infarction coming mostly from the non-calcified and therefore we need to treat aggressively? We think yes, but that is not the majority. The majority is probably from rapidly progressing calcium and resulting in ischemia. So it's either this inflammation on the non-calcified or it is the ischemia that develops on following the severity of the stenosis in the vessel. So it's two components. It's either the inflammation or it is the ischemia. And these two are hard to put that together. Then people reach out to the artificial intelligence and they come with results, but it's very hard to understand completely what is now the way to do in terms of sequential testing, and based on the results that we find, what should our action then be? So I think that what you propose is very valid, and that's also how we do it in the clinics.
Thank you very much, Jiron, for this comprehensive talk and question answer session at the same time. But we are running short of time because we will move
Yeah,
on
my
to the next
apologies that I had
speaker.
to go, but I had to do something for my son, so that was the reason that I got a little bit nervous.
Thank you, welcome. We will
All
move
right.
on to the next speaker now. Intracoronary imaging and coronary artery disease by Javed Ahmed Saab. Online?
Hi, good afternoon. Can I just share my screen, please?
Yes, we can hear you.
Thank you.
You can proceed.
Yeah, I'm just trying to share my screen and it's not coming up. Is there anything else I have to press? Don't know.
I think you have to place your camera in front of you. Its placement requires little adjustment. I think there is little IT adjustment required at the moment. We are waiting for the OK signal from the IT segment to proceed with the talk. ऑनलाइन टाइम ओवरलैप मुश्किल हो जाएगा. I think there's some adjustment problem with the IT at the moment, and we will apologize with the further timing with the Dr. Javed Ahmed, and we'll move on to the next speaker. I would like to invite Dr. Nadir Khan Saab for his talk about the IVS and OCT in coronary artery disease.
Thank you very much. Can I have the slides, please? So I'll be talking about IVUS and OCT in coronary artery disease. So it was the ultimate trial that compared angiography guided versus IVUS guided PCI. And we can see here that the IVUS guided PCI, the target vessel failure was much less as compared to the angiography guided PCI. And in the IVUS guidance, they again divided it into suboptimal and optimal PCI depending upon the stent expansion, the landing zone, or any edge dissection. So in optimal PCI, there was again a statistically significant difference from the suboptimal PCI. So in the Lumen trial, the minimum stent area rather than the angiography guidance was used, but there wasn't much difference, but it led to more stenting. So if the distal to proximal MLA was less than 4, and if there was an edge dissection, so it led to stenting at the distal edge. So the Renovate complex PCI trial, in which there was an angiography guided versus the intravascular guided, the death, target vessel related myocardial infarction, both were less, in which intravascular imaging was used to guide the PCI. So in the October trial, again the OCT guided PCI had a much lower MACE as compared to the angiography guided. In STEMI patients, again there was 15% reduction in stent implantation with OCT guidance. So the indications in coronary interventions being that in intermediate stenosis of the left main, IVUS is reasonable to help define the lesion severity. And in patients undergoing stent implantation, particularly in cases of left main or complex coronary stenting to reduce ischemic events, it's again 2A. And in patients undergoing stenting, OCT is reasonable alternative to IVUS for procedural guidance, again 2A. And in patients who have a stent failure, so imaging is a 2A indication. And in patients with ACS undergoing complex stenting procedures like left main or multivessel, intracoronary imaging or OCT is recommended as a class 1 indication. And this is back in 2021 ACC guidelines. So these are the, this is the summary of the indications in which class 1 being an ACS scenario with left main or complex PCI. So the sizing variability between the different modalities, the OCT is the most accurate, the IVUS slightly overestimates, QCA underestimates, and the visual estimate is there is too much inter-observer variability in the visual estimation. So OCT as compared to IVUS, the penetration power of the OCT is less as compared to IVUS. Other than that, the OCT gives a very good resolution and nicer pictures. So this is an IVUS image showing a normal vessel with intima, media, and adventitia. So this is again another picture with plaque present under the intima. So we can use coronary imaging for PCI planning and optimization. So planning, we need to identify the landing zone, the stent diameter, the stent length, and the lesion preparation according to the lesion morphology. And optimization like stent expansion, apposition, edge dissection, or an edge plaque shift. So landing zone selection has to be less than 50% plaque wherever your stenting is landing in the distal or the proximal portion. This calculation is done by the machine itself, so we do not need to remember this formula. So this is an image showing where the stent is in a place where the plaque burden is more. So this is not an optimal location for stent placement. However, on the right side, you can see that the plaque burden is 36%, and you can place the edge of the stent in this area. So you can use the distal reference lumen diameter for the stent size or distal EEM, and do not use the EEM at the lesion because of positive remodeling. You can oversize the stent. So here you can see angiographically as well as IVUS images. The distal reference is around 3 millimeters. At the lesion, it is more, and the proximal reference is around 5. So you can see finally the lumen areas are quite adequate after the stenting. So stent length can only be determined if you have the auto pullback feature available. Otherwise, by a manual pullback, you can't sort of determine the length of the stent. So there are different types of plaque morphology. So there can be a soft plaque, a mixed plaque, and a calcified plaque. And heavy calcium is defined as a greater than 270 degrees, length of greater than 5, and thickness of greater than 0.5 millimeter. So you would need some kind of plaque modification like rotation atherectomy or any other procedure to have optimal results. So these are again various types of plaque. So how to differentiate between a fibrotic and a calcific plaque? So there is no signal dropout, although the fibrotic tissue is also very echogenic, just like the calcium, but there is no signal dropout. So calcium, dense calcium will cause a signal dropout on the IVUS image. So here again are pictures of calcified plaque, a 90-degree arc. There's deep and superficial calcium in the next image. Then there is a 180-degree arc, and then there is a 270-degree arc. So you can see that there is a signal dropout behind the calcium. So here in the first image you can see the calcified nodule. There's another calcified plaque which is more than 270 degrees, and after using the IVL you can see that there are fractures in the calcium. So post-stent, the well-expanded stent would be greater than 90% of the distal reference. Or you can use absolute values like left main of greater than 8 or non-left main of greater than 5.5 millimeter square area. So again, in longer stents, the proximal MSA should be 90% of the proximal reference, and the distal stent should be from the distal reference. Now, what to do if there is an edge dissection you see on IVUS? So you will have to place another stent if the dissection either extends to the media, is longer than 3 millimeter, or is greater than 60 degrees. So for a greater than 50% plaque burden at the edge, an undersized balloon inflation or leave as such. No further stenting is required. So for malapposition, you can use a more aggressive post-dilatation. So again, the same thing, that if you have a dissection that is larger than 3 millimeter, greater than 60 degrees, going into the media, you need to stent that edge dissection. And the post-dilatation in case of under expansion should be with an NC balloon measured from the distal external elastic membrane and inflate at high pressures. So this is the final slide, and this is showing suboptimal versus an optimal result after a PCI. So in the left images, you can see that the stent is under expanded and there is an edge dissection. And on the right images, you can see that the stent is placed in a place with less plaque burden, the expansion is satisfactory, and there is no dissection. Thank you very much. Absolutely, absolutely, that's true.
So when the test came in, the idea was to go from healthy to healthy.
Yes.
But bare metal, it used to be disease to disease or as a disease. But why are we still having these stents placement?
सर मुझे आवाज आ रही है
मेरी आवाज आ रही है?
सर की आवाज तो आनी चाहिए सर
My basic question is this, that when stents came in, with the bare metals were the initial ones, at that time it was disease to disease, less disease to less disease, and when the deaths started coming in, it was that we should go from healthy to healthy. Of course, there's a vascular size discrepancy at times, especially with LED, happens a lot, because if your lesion length is long, then you end up with other debates also. But even today, in your opinion, is it our eyeballing which is actually making us leave the stent at the disease segment? Or are we, because we are saying that, okay, let's economize, go to one stent rather than two stents? Or you're saying something else? So, in your opinion, as your experience, what do you think?
Actually, sir, there is too much variability as far as eyeballing is concerned. So that is the reason for IVUS guided optimal PCI. So a portion in the coronary artery might appear normal to you angiographically, but there might be more than 50% plaque burden. So you put a stent there and you might end up with restenosis. But if you have done an IVUS and you exactly know where the distal edge of stent needs to be placed.
People like me, unfortunately, and now you also, we have to talk about economics of the whole procedure. So when you're talking of the economics and the need to justify that versus, so you're trying to save on a stent and you're spending 2 times the price or 3 times the price of a stent. So that becomes the trick question, that, you know, okay, rather than I was just put an extra stent and get it over with, because that will cut down your time also and that will cut down on your cost also. So is that correct assessment? I know technically it is not appropriate because you should do the best possible job. But this is where we are sort of. So do you think it is time that now, rather than having the price of your procedure on the basis of how many stents, it should be one price, like what in States or UK they are doing, that procedure is labeled, if I remember right, sir, the figure, Bidesa would be, if I remember right, the figure is 1.75 stents per angioplasty. You may go, so you'll be charging everyone 2 stents. If you make 1 good enough, 2 good, 3, you've had it. So it is something like that. So can we do something, in your opinion?
Sir, I think in practice what we are doing, nobody is doing IVUS that frequently in routine angioplasty. So in practice, what we are doing is that whatever appears angiographically normal, we are placing the stent there, and most of the times the results are quite good. So this is what we, and even in the developed countries, the penetration of IVUS is not 100%. So it might be 20-30% in routine PCIs, but in complex PCIs, if you are doing a left main or a multi-vessel, so then I think IVUS will be very useful, especially in left main.
Thank you, sir, for this thought-provoking presentation. Now I would like to invite the next speaker, Professor Muhammad Ayub Saab, for his talk about the CT imaging in cardiovascular diseases.
Bismillahirrahmanirrahim. This talk is about clinical applications of cardiovascular CT. Cardiovascular CT use criteria has been defined by ACCF along with multiple other bodies, and they have defined appropriateness criteria. And if these criteria fall between 7 to 9, then that indication is considered appropriate. If it is less than 3, then that is considered inappropriate or like class 3 indication. And if it is between 4 to 6, then that is just borderline case or uncertain indication. So considering these criteria, various indications has been defined. Cardiac CT is of two types. One is the non-contrast calcium score. The other is the CT coronary angiography. Calcium score, we have already talked about. It has got great prognostic value in asymptomatic people, not in symptomatic people. And the different values are associated with various levels of risks. And they can be used as a guidance to the statin therapy. As far as the contrast angiography is concerned, it has got reasonable sensitivity and specificity. But the best thing about CT coronary angiography is that it has got excellent negative predictive value. So this is a very good tool when you need to rule out coronary artery disease. So CT angiography is indicated if you have a patient with chest pain syndrome and there is intermediate likelihood of coronary artery disease. This test is appropriate whether the patient is able to exercise or whether the patient is not able to exercise. This is example of normal coronary angiogram, an abnormal coronary angiogram in patient with intermediate likelihood of coronary artery disease. Then when there is an equivocal stress test, you do an ETT test, but it is equivocal, then CT coronary angiography clarifies. And it can rule in or rule out coronary artery disease in these patients. It is an excellent test when you are suspecting coronary anomalies. Sometimes you are not able to engage coronary arteries and the anomaly is the reason, and then CT angiography can define the anomaly in its entirety. A patient with coronary fistula, then if your patient is symptomatic with acute chest pain and the troponins and cardiac enzymes are negative, but still patient has got intermediate likelihood of coronary artery disease, then this test is indicated. This is a patient with normal coronaries presenting with acute chest pain. Then this is very good test for study of the grafts as well as native coronary arteries in patients with post-cabbage symptoms. Then in patients with stent, this test is not very good, but you can use this CT coronary angiography for left main stenting and for stents bigger than 3 mm. But for smaller stents, this test is not very good and you are not able to visualize what is inside the stents. CT coronary angiography can be used for assessment of cardiac function, especially when the information from echocardiography is incomplete. So otherwise, this may be a complementary information in patients undergoing CT coronary angiography. This test is also appropriate in patients with valvular disease, whether it is native valves or prosthetic valves. You can study their stenosis, regurgitation, and valve area, and all the features of the valves. Then this test is also appropriate in patients with suspected cardiac masses. In patients with suspected pericardial conditions like constrictive pericarditis, you can see the rim of pericardial calcification and the other features of constrictive pericarditis. Then this test is indicated in patients with undergoing radiofrequency ablation for atrial fibrillation for defining pulmonary venous anatomy. This test is also indicated in patients with planned biventricular pacing for study of the coronary veins. Then for all aortic conditions, whether it is aneurysm, whether it is dissection, whether it is obstruction, the aortic condition, or in all aortic conditions, CT angiography is a useful investigation as an appropriate indication. In patients with suspected pulmonary embolism, CT angiography is appropriate investigation. In patients with complex congenital heart disease, like this patient with congenitally corrected TGA, CT gives perfect information. In other patients with complex congenital heart disease like anomalous pulmonary veins, ASDs, VSDs, this test is indicated and appropriate. For study of the branch vessels of pulmonary arteries, this test is appropriate. For other complex congenital anomalies like truncus arteriosus, this gives good information and is appropriate test. In patients with big PDA, patients with aortic interruption or coarctation and its complications, patients with total anomalous pulmonary venous drainage of any type, patients with aortopulmonary window, patients with congenital anomalies like Epstein anomaly with right side involvement, patients with pulmonary arteriovenous malformations, this test is appropriate. Okay. So the final word is that cardiovascular CT is a useful investigation covering almost all aspects of cardiovascular disease management. Thank you.
You?
There is no formula. Actually, this has been defined by experts. I don't know what exact formula they used, but they did a scoring system starting from 0 to 9. And according to those experts, the average value of their scoring was taken as the score for that particular indication. And if it fell then more than, if it was more than 7 to, and between 7 to 9, then that was considered as an appropriate. I don't know exactly how those bodies define that criteria.
Ayub, excellent presentation.
Thank you, sir.
If your patient has a calcium score of 400, would you continue to do the CT angio, or the other, if I word it differently, at what level of calcium score you wouldn't want to do it?
Actually, nobody stops at any calcium level. So once patient comes for CTA, then no matter how much calcium is, some people say it should be less than 400, some people say less than 1000, but practically nobody actually stops.
Why not?
There are obviously the information would be limited. If there's a lot of calcium, the information provided would be less accurate, the coronary stenosis would be overestimated. But if you are compelled to do it, then there are certain tricks, like you have to reduce the heart rate to very low level so that there's very little coronary motion, and you also try to dilate the coronary arteries a little bit so that the impact of coronary calcium is less on the lumen. So in that way it may be useful. But practically most of the people don't stop at any calcium less than 1000. Less than 1000.
Probably usually. That is because of the revenue which it generates.
Maybe that is a factor. But if it talks to me just after doing coronary calcium, like just today, one tech from one center called me and asked me that coronary calcium is about 1200. So I asked him to send the patient back to the consultant and tell him that the information provided would be very limited. So will he reconsider doing a conventional angiography instead of doing this? But if he insists on this thing, then we can do it with special precautions. Otherwise, he should consider other modalities instead of going for CTA because information is limited.
Yeah, I always thought that this CTA is, its sensitivity is, sorry, specificity is about 97% for exclusion. For assessment of stenosis percentage, what is it? Is it beyond 60%?
Sorry?
Sorry, excluding the disease,
As
if the calcium is 0, then it's 97%. But what is the sensitivity about its positive findings, like percentage of stenosis?
the positive predictive value is relatively limited, if there is, especially when there is a lot of calcium. As far as the negative predictive value is concerned, that is excellent. But as the earlier speaker said that the negative predictive value is 100%, I don't agree with,
No,
with that it is 100% negative predictive value. That would be 100% only if you have excluded all patients with technical artifacts and the limitations of the CTA, and only include those patients who have got excellent images. Only then you will be able to exclude coronary artery disease with 100% certainty. Otherwise, no test is 100% accurate.
No, first hand, I mean, I had to put 3 or 4 stent in a young man of 40 with calcium score 0. So I think it's no more than 97%.
Yeah.
That's what the literature says.
So basically, in your patient, it must have been the soft plaques there.
Yeah.
If the calcium score was 0, the soft plaques can be there.
Today morning, I showed one case in which the patient was symptomatic and the calcium score was 0. But when we did CTA, the left main stem was 100% occluded and patient has tight stenosis in the RC as well. So calcium score is of no value in symptomatic people. So that is not the test. That is only an additional test if the patient is already undergoing CT angiography, then obviously calcium score is done with that. Otherwise, calcium scoring is not the test for symptomatic people.
It just shows you the atherosclerosis there.
Yes, yes.
So
Let's
we
move
are
on, please.
getting short of time already, and we have already swapped this session before the previous session. Now we are connected again with the Javed Ahmed Saab, and we will be talking about the intracoronary imaging and coronary artery disease. Can you hear, sir?
Can you hear me?
Yes, yes, we are.
Hello, can you hear me?
Yes,
Oh.
you can proceed. Thank you.
Thank you very much for inviting me to give a lecture on the basics of intravascular imaging. I am Javed Ahmed, Professor of Interventional Cardiology, Freeman Hospital, Newcastle upon Tyne, United Kingdom. Can I have my first slide, please? Unfortunately, there is no projection of slides on the screen.
We can see your slides. You can.
I can't see here.
We can see both of you, the slide and yourself. So go ahead, please.
Slide is visible. You can, if you can see, you can start with your presentation.
Okay, thank you. Intravascular ultrasound and the new imaging modalities such as OCT are extremely useful in guiding the intervention and also for assessment of coronary atherosclerosis. Basically, these are techniques where you look inside the coronary arteries or peripheral arteries where no other technique would enable you to look inside. Uh, what are the common and normal indications for intravascular imaging? You can use intravascular imaging and OCT to evaluate the coronary and peripheral arteries, guiding stent placement, plaque characterization, guiding PCI, stent optimization, and assessment of left main coronary artery disease and guidance in complex cases. There are two types of intravascular systems. One is called mechanical, which produces sharper and more crisp images, and that is more commonly used. And the second one is the electrical system, which is slightly easier to use, but the image is not as clear as the mechanical system. And in this slide, you could see that this is an image from the mechanical system, and that shows very clear demarcation of intima, which is the white layer inside the coronary artery. And then you could see media, which mainly contains the smooth muscle, and that appears black. And then the adventitia, which is outside the media, that is quite bright and echogenic. And here you could see the wire visualization when you actually insert an IVUS probe inside the coronary artery. And this is a picture showing a normal on the left-hand side and a disease vessel on the right-hand side with fibro calcific plaque. And this is an example of concentric plaque on the left-hand side and a centric plaque, which is mainly on one side of the coronary artery. And this is a soft and fibrous plaque as compared to calcified plaque. And this is a very small amount of calcium with an arc of less than 60. And this is a medium-sized calcium, which is close to an arc of over 150 or 180. The next one is heavy calcium. It's also called the napkin ring, where the whole circumferential part of the artery is calcified, as you could see no shadow behind the calcium. So that is the way to recognize immediately that there is calcium in the coronary or peripheral arteries. And this is an example of a fully expanded stents where the stent studs are fully opposed to the wall of the vessel. This is just an example of underexpanded or malopposed stent studs. You could see at 6 o'clock position, the studs are not fully opposed to the vessel wall. And this is an example of thrombus, how it is visible on the IVS, although thrombus is much more easily recognizable on OCT or OFDI. So this is an example of fibrous plaque dissection extending into the intima on the left-hand side, and on the right-hand side, there is fibrofatty plaque dissection extending into the media. There can't be any more clear picture than that, because when they, simple way to recognize dissection, when there is a break in the intima or when the break extends into the media, that is a dissection on intravascular ultrasound. And this is just an artifact, and this usually indicates that the catheter is bent. Then you have to use a new catheter. So the second more recent imaging modality is optical coherence tomography, which is called OCT, and also The other type is called OFDI, and it offers more high resolution, which could visualize inside of the coronary artery more effectively. OCT uses light rather than ultrasound-like intravascular ultrasound waves to create detailed images of the arterial walls and surrounding structures, including plaque, thrombus, and stent placements. OCT or OFDI also offers superior resolution compared to IVUS, allowing for more precise assessment of plaque composition and stent deployment. And this is an image of a normal coronary anatomy. As you could see on OCT, there is a clear image of the intima, and then you could see slightly darkish media, and then again echogenic bright adventitia, and then you could see the vessel lumen. So this is a slide which shows a normal vessel, and then it shows different plaque morphologies, which includes lipid-rich plaque as labeled, as well as calcium, and on the panel, which is uh, labeled as L, and it demonstrates macrophages, which are cholesterol containing deposition. And this is an example of what the calcium looks like uh, on OCT, and this is a picture of a sphere calcium with an arc of at least more than 300. And this is a image of white versus red thrombus. The simplest way of recognizing is that white thrombus is on the left-hand side, and there is clear lumen visible behind the thrombus. That's why it is called the white thrombus. And on the right-hand side, there is thrombus, but it is adherent to the vessel wall. So that is the simplest way of recognizing whether it's a white and or it is red thrombus. And then the OCT demonstration of a normal lumen in panel A, and then B is a dual lumen due to dissection, and C is a dissection flap, which you can very clearly see, and then D is again dual lumen. And now, what is the difference between plaque erosion or plaque rupture? I will show you the OCT images of that. The plaque erosion is usually characterized by thrombus formation on an intact, though potentially thin fibrous cap without evidence of a rupture. In plaque erosion, the intima is usually intact. OCT can identify erosion by absence of ruptured fibrous cap at the culprit lesion and the presence of thrombus overlying an intact plaque. The plaque rupture involves a break in the fibrous cap, exposing the lipid-rich core to the bloodstream, leading to thrombus formation. So plaque rupture is usually associated with thrombus, whether it's the white or red, visible on the OCT. OCT can also identify plaque rupture by visualizing a disrupted fibrous cap. So this is, you could see on the right-hand side, there is no disruption of the intima, and there is some irregularity of the inside of the coronary artery and of the intima, which is plaque erosion. And on the left-hand side, there is disruption of the intima with a little bit of thrombus formation, and that is plaque rupture more consistent with ST elevation myocardial infarction. And this is an example of spontaneous coronary artery dissection, where you could see a false lumen, and all the way in these three top images, and also on the longitudinal resolution. And then this is another example of spontaneous coronary artery dissection, where you could see the caliber actually reduces considerably in the distal LAD, and you could see on the OCT that there are true calcified sorry, 2 patent lumens. And this is an example of fully expanded stent on OCT, where all the stent struts are opposed against the vessel wall with no gap between the stent struts and the arterial wall. And this is just a comparative example of under expanded stent on OCT. The fully expanded stent is in panel A, and under expanded stent in the panel B, and then fully expanded stent on IVUS in panel C, and under expanded stent on IVUS is panel D. And this is just a case which was the first ever case done by myself as a live case. This patient had severe Parkinsonism and aneurysmal formation in the distal segment of the left main stem as well as proximal LAD. So this was performed, the first ever IVL on a left main stem after wiring the lesion. As you could see, the IVL in action where the balloon is inflated. And now you could see that after doing the IVL, the patient had a single stent inserted, and it looks back to normal. So this is another picture. And this is a picture where the IVL balloon is still being inflated. And this is an example of a case which I did with IVL, where you could see the cracks, and then after the stent insertion on intravascular imaging, the stent looks fully expanded. And this is another case which was balloon uncrossable and severely calcified right coronary artery lesion, and where you could see that it is quite tortuous. And this patient was treated with a guide catheter extension along with laser. And you could see the laser catheter is almost across the lesion. There was no other modality which could have crossed this lesion. And this is just an example of the laser cuts. And this is just an example of the balloon being inflated after treating the artery with laser. And in fact, in this, after the initial balloon, because of severely calcified artery, IVL was used as well along with laser to have a hybrid approach. And this is the final result of after treatment and intravascular imaging. Thank you.
Thank you, Dr. Javed, for your detailed talk about the topic. We are getting short of time. That's why I think the question answer should be skipped, or if it is mandatory, only one question we can take.
Sure.
Good. Okay, thank you. I would like to invite Dr. Hassan Salim for his talk about the role of CMR in cardiac pathologies.
Bismillah ar-Rahman ar-Rahim. So I'm going to start my talk with this ayat which says, "They said, glory to you, we have no knowledge except what you taught us. You, only you, are all knowing and all wise." So I'm basically a radiologist by profession. I'm a cardiovascular radiologist working at IDC. I've been involved in cardiac MR for about, I think, 8-9 years now. So I'll just, because the time is short, I'll just quickly go through cases. So the people who are interested in cardiac MR and who have some basic knowledge, I'll just quickly go through some of the cases. beginning with the normal scan. I hope you can see my, yes, right. All right, so this is basically 2-chamber view. The other one is 4-chamber view. And this is the 3-chamber view where you can see the blood moving from LA into LV and then going into the aorta. You can go see LVOT as well. So in MR, there is no radiation, there's no time limitation. You can get as many planes as possible. So this is primarily a cine white blood imaging. Not going to go into the detail of the physics, but this is primarily a cine imaging where we play the loop and we can see the contractility of the myocardium, and we can also see the movement of the blood, whether there's any turbulence or any other problem. Then we go take a stack extending from the apex. So now we are taking the stack which is moving from the apex towards the base. So now we are bisecting the mid cavity. You can see some of the papillary muscles there. And then this is the right ventricle and this is the left ventricle. And we are basically looking for this figure of 8. The aorta is arising right from this part so that we can plan our next slice. This is a black blood image. This is primarily inversion recovery. Just a small physics. It's an extra impulse, which is 180 degree. You have to get rid of the white blood signal from there so that you can get a good morphological assessment of the muscle of the LV and other areas as well. So this is T1, this is T2, this is T2 fat sat, or you can say stir image, and this is, you can also get into another plane. You can take short axis, you can take LVOT, wherever the pathology is. So primarily this is for the edema imaging in patients with MI, with patients with myocarditis, and all the inflammatory conditions which will render edema within the myocardium. This is followed by the perfusion scan. If you are running stress scan, usually we use adenosine in Pakistan. Regular adenosine is not available to my knowledge. So contrast, as you can see, we have injected gadolinium. It is coming from the right side to the left side, and then it is disseminating into the myocardium. So by adenosine injection, followed by the rest phase, you can see whether there is resting ischemia, whether there is reversible ischemia, or whether there is a fixed infarction. This is followed by LGE images. These are late gadolinium images where you can see scarring. So this is a normal myocardium on LG images, which is all jet black. You can see the white contrast within the lumen. This is a normal myocardium on the short axis view taken at near the apex, mid cavity, as well as at near the base. Again, on 2-chamber view, 4-chamber view, and 3-chamber view, you can take as many images, as many planes as possible within a certain frame, because the gadolinium is going to fade away. Just to give you a rough idea that how you're going to differentiate based on the scar burden and where the scar is. So that is very important. So in the first slide, you can see the ischemic pattern. Mostly the white scar, this is the gadolinium, which is basically pooled in the scar in the infarcted tissue where it's necrosis. It's not letting go the contrast. This is the normal myocardium. So subendocardial and transmural ischemia, obviously, and non-ischemic patterns are all other patterns like in mid-wall cavity. We can see it in the dilated cardiomyopathies, myocarditis. Then at the RV attachment site, this is HCM. Sarcoidosis, its favorite site is posterolateral wall. Then epicardial, it can be seen in again sarcoidosis, myocarditis, Anderson-Fabry, and global endocardial enhancement is basically seen in amyloidosis. We're going to, inshallah, go through all those cases. This is a very novel sort of a software which is T1 mapping. It is very useful in patients where we cannot inject contrast, cases with amyloidosis where the renal function is also compromised, EGFR less than 30. We don't recommend giving contrast anymore. So the patients who come from the renal centers like PKLI, we then go for T1 mapping without injecting contrast. We get some idea that whether there is underlying infiltrative disease or not. So in this case, this is a case of myocarditis. You can see the T1 native. I hope you can see the light. T1 native value is is more than 1200, which is higher. So this was the case of myocarditis with edema. This is just a rough map where you can see that the higher values in the red codes This is basically the domain of the amyloidosis. The higher the T1 value, without injecting contrast, you can see the domain where the TI value is high in MI, amyloidosis, chronic MI, acute myocarditis is somewhere in the middle, followed by the HCM and DCM. And then on the lower side where you can see the blue coding, this is low TI value where when the fat is there and when the iron is there, the T1 mapping also gets reduced to less than 900 milliseconds. Then we can also do pericardial tagging for patients with constrictive pericarditis. I'll show you the case, but just to get an idea, in the diastolic phase, we apply the strips and the grids, and you can see in the diastolic phases, the grids and the stripes are breaking up. So that means it is giving you a good diastolic phase. There is no underlying constrictive pathology. So it's very novel, hardly, I think, 10 seconds sequence. Iron quantification is very easy to perform again. I get a lot of patients with thalassemia. So we do simultaneous cardiac and liver imaging. Takes again a hardly 10-second sequence in which we can quantify and map out the iron. The red part is all iron. It is on the higher side. So it is more of a, you can see the focal deposition rather than a diffuse deposition. So these are multiple reference ranges. In cardiac T2 star, where the value is less than 10, we consider it as a very severe iron overload. And these are the patients which are definitely going for chelation therapy. Coming to the cases, first we are going to see the DCM. Here you can see a very slow moving heart. It is hardly moving. EF calculated was less than, I think, 15%. Here you can see that LV, and actually all the chambers are dilated. Underlying, there was ischemia. There's a case where there was no ischemia was found. Again, you can see dilated multi-chamber enlargement, and the ejection fraction was less than 20%. Now, cardiac MR has become sort of a gold standard, but nothing is 100%, but it's very novel in that sense that the ejection fraction of the left side and on the right side, it's very easy to reproduce, and it has low variance. Viability studies are very common. Here you can see that if you can appreciate that there's thinning of the interior wall and the apex as compared to the basal segments. Here you can see that it is hardly moving. It is very hypokinetic on two-chamber view. On LGE images, you can see scarring in the apex, and we can see there is some black normal tissue there, telling us that there is some viability in this LAD territory, whereas apex is there's a transmural involvement, so that means that it is gone. There's no viability in this area. So again, this is LAD territory infarct, and this is again the septum, which is subendocardial, not transmural, and there is some viability there, whereas the apex is somewhat transmural in this regard. It's very easy to, again, it says very low variance, sorry? Actually, so I'll finish, no worries. I'll finish. So this is just how to do the viability scan. Thank you very much.
Thank you, Dr. Hassan Salim. Now I would like to ask the Dr. Shehbaz Sarwar for his talk about the echocardiography of right ventricle.
Okay. So, right side of the heart was practically the forgotten ventricle, but it is not anymore now, and I will be talking about that and about the latest guidelines which we have now. So by and large, people have been doing eyeballing to assess the right side. In fact, generally, people omit right side of the heart, do not comment on that when they are doing echo, just comment on the left side, don't comment on the right side. And if somebody by mistake comment on that, it is just by eyeballing. So by eyeballing and quantitation, you see the various studies have shown that quantitation clearly outnumber the qualitative assessment of the RV. So we have to do it by qualitative methods. So why RV matters? Because of the key clinical impacts of the outcomes in the pulmonary hypertension, heart failure, congenital disease, and ICUs. So RV failure is practically a prognostic bomb, and RV dysfunction predicts mortality independent of left ventricular ejection fraction. In fact, our cardiac surgeons are really afraid because whenever they see right ventricular dysfunction, they are really afraid to go in. And this is how the world sees it. The right ventricular size and function, most of the European labs, majority of them academic hospitals, and size of the RV is done by only the basal diameter, and rest of the parameters are done very rarely. Similarly, the function of the RV is done by TAPSE, and the rest of the parameters very, very rarely. So this is how the world sees that, and this is how majority of the people in Pakistan are also doing it. So important thing is that we must do the TAPSE very properly. We have to align the angle very properly, and if we can use anatomical M mode to measure it properly, that would be nice. And similarly, very dense echo of the tricuspid annulus should be used for measurement. But we must remember that interpretation of RV function is not just TAPSE. Because of the complex geometry, crescent shape and heavy trabeculations, longitudinal shortening and radial thickening, and all other effects. So we have to do the TAPSE or the S prime, RV IMP or T index, and I generally prefer a tissue Doppler measurement of the IMP if I am doing that, but generally that is not a very favored kind of reading for RV analysis. Fractional area change is an area which should be done routinely by everybody, and we have to do the fractional area change by RV focus view. Normal is more than 35%, and this is one of the recommended methods of quantitatively estimating the RV function. Whenever we are doing it, we have to include the trabeculations and bands inside the chamber. So this is one of the methods which is in the guidelines as well. Now, another new concept, that is the RV-PA coupling. This reflects the relationship between RV contractility and PA afterload. This is a key determinant of RV performance and prognosis. Gold standard is ease by EA, that is an invasive measurement, and the surrogate is an echo-based assessment of TAPSE by PASP ratio. This has got strong correlation with invasive RV-PA uncoupling and prognosis, and the normal, which has previously been like about 0.5, now the recent guidelines say that 2025 guidelines say that it should be normal cutoff is 0.31. We can do TAPSE by PASP, or if we can't get the pulmonary artery pressure or TR is not there, then RV fraction area change can be replaced in the numerator, S prime can be done, or longitudinal strain can be done. So all these methods are emerging parameters. Some are investigational, but presently we rely more on TAPSE by PASP. So why it matters? Because it is an early marker or RV dysfunction in pulmonary hypertension, heart failure, and ICU settings. It predicts outcomes better than RV function alone or PA pressure alone, and guides therapeutic decision making like pulmonary hypertension management or RV failure. It shows how well the right side of the heart works against the pressure in the lungs. We can do global longitudinal strain or 3D imaging, but that is going a bit beyond the scope of presentation. So we must remember there are certain red flags in RV dysfunction. If we see IVS flattening eccentricity index is there with pulmonary hypertension, that is a red flag. If you see McConnell sign, that is pressure overload, that is a red flag. If you see with right-sided enlargement, pericardial effusion, that is a red flag. And IVC and right atrial pressure, if it is increased, that is a red flag. So to conclude, RV is vital. It's sensitive to loading conditions. Echo is practical, but multimodality is ideal. It's important but challenging because of the complex geometry and coarse trabeculations. Eyeballing is not recommended. Qualitative assessment is recommended, especially for RV, subtle kind of RV dysfunction. We must use multiple acoustic windows and RV focused views. We must also always do RVPA coupling by TAPSI by PSP. And especially we have to be careful post-cardiac surgery when the TAPSI is generally reduced because of a pericardiectomy. So we should use a fractional area change. And we must remember that if RV fails, the patient may fail even with a normal LVEF. We have very recent guidelines in March. These are the American Society of Echo guidelines on the right side of the heart. And the important points in these are that the mean PA pressure has been reduced to 20 to tell about the pulmonary hypertension, and they have followed the European Society guidelines. We must look by the RV focus view. We should do the TAPSI as prime and fraction area change. Strain and 3D whenever applicable should be done. And the hemodynamic assessment, right atrial pressure, systolic pressure of the RV, pulmonary artery and diastolic pressure, pulmonary vascular resistance, RVPA coupling, all these things should be done. And lastly, for hemodynamic calculation, RV outflow tract acceleration time, which was not done in the last guidelines or briefly mentioned, now they are recommended. Pulmonary vascular resistance, which was not done previously, is not recommended. And RVPA coupling, which was not mentioned or included in the previous guidelines, it is very strongly recommended in the recent guidelines. I think I have finished in time and the recently allotted time. Okay.
Thank you, sir, for completing your talk right in time bracket. We will move on to the last talk of this session by Dr. Fateh Ali Tipu about the echocardiography of left ventricle.
Can I just ask a simple question from?
Sure, sir.
Just a very small, simple question. What is the best utility of RV assessment?
मेरी तो इसमें टॉक ही ना
देखिए बेस्ट यूटिलिटी ऑफ आरवी असेसमेंट जो है इसमें मल्टीपल पैरामीटर्स हैं. कोई एक सिंगल पैरामीटर अभी तक हम नहीं कह सकते बिकॉज ऑफ द फैक्ट मैं जो बात कर रहा था इसकी कॉम्प्लेक्स ज्योमेट्री है. इसमें हमें 2-3 चीज़ें लाजमी करनी चाहिए हर एक में. टैप्सी ज़रूर करनी चाहिए. एस प्राइम इज़ ऑलमोस्ट सिमिलर इंफॉर्मेशन. फ्रैक्शनल एरिया चेंज विद एन आरवी फोकस व्यू हर एक को करना चाहिए. इन दोनों को मिला लें तो आपकी बड़ी अच्छी इन्फॉर्मेशन आ जाती है. और जहाँ पे मुमकिन हो ये RVPA कपलिंग को देखें, ये सटल RV एबनॉर्मेलिटीज़ को दिखाता है. माई प्रैक्टिस नाउ इन रूटीन इज़ दैट आई डू टैप्सी एस प्राइम, फ्रैक्शनल एरिया चेंज, RVPA कपलिंग. ये 4 चीज़ें करें तो आप एक रीजनेबल एस्टिमेट दे सकते हैं. अगेन उसके पे भी आप 100% नहीं.
We are short of time. Let's move on. Let's move on.
Okay, Assalamu alaikum. So the topic of my talk is assessment of LV function by strain imaging. So there are different variables which we use for the assessment of LV function. I'm not going to discuss all these, but there are pitfalls of conventional methods. Conventional echo methods are indirect measures of systolic myocardial performance, and ventricular geometry can affect the analysis from conventional methods. So these are the pitfalls. If you look at the first image, the EDV is 125, ESV is 70, EF is 56, and stroke volume is 55. So this looks okay. But in the next image, if you see, the LV is dilated, volumes are increased, EF is low, but stroke volume is good. Stroke volume is still 70. And in the third image, if you see, the LV size is small, EF is normal, but the stroke volume is reduced. So these are the pitfalls of conventional methods. So there was a need for a more robust way of assessment of myocardial performance, which can determine the direct quantitative myocardial performance and also assess the regional myocardial function and evaluate geometry independent LV function. And in fact, myocardial strain fulfills all these criteria. So what is the strain? It is the magnitude of deformation. I'm not going into detail of that. Actually, the left ventricular myocardium undergoes a complex multi-dimensional deformation during the cardiac cycle. And there are three main types of strain. One is the longitudinal strain, the other is the circumferential strain, and the third one is the radial strain. The longitudinal strain denotes shortening of the LV along its long axis. The circumferential strain depicts reduction in the circumference of the LV cavity during cardiac cycle, and the radial strain denotes thickening of the LV wall along its radius. So we can measure the strain by two ways, either by tissue Doppler imaging or by speckle tracking. Speckle tracking is the commonest way of measuring the myocardial strain. So in which conditions we can apply the myocardial strain? Among the three types of strain, longitudinal strain is the most commonly used, and because we know the standard values and there is less inter-vendor variability, so longitudinal strain is the most commonly used strain, and these are the conditions in which we can apply the myocardial strain or the longitudinal myocardial strain. So cancer patients are the most common patients in which we use the myocardial strain. When reduction in LVEF during chemotherapy is established, it may be too late for treatment to allow complete recovery. So reduction in myocardial strain precedes significant change in LVEF. So global longitudinal strain has emerged as an early marker of cardiotoxicity. And according to these societies, the evaluation of adult patients during and after cancer therapy, they recommended use of global longitudinal strain. And if there is a reduction of 15% or worsening of 15% global longitudinal strain, then it's clinically significant. The other conditions in which we can use myocardial strain or longitudinal myocardial strain is the cardiomyopathy group, especially the hypertrophic cardiomyopathy, in contrast to LVEF, which very often is normal in hypertrophic cardiomyopathy. Longitudinal strains are reduced in early stages of the disease, and longitudinal strain is reduced at the sites of hypertrophy, commonly in the interventricular septum, because the myocardium here is not normal. There is myocardial disarray as well as myocardial fibrosis. And the current clinical practice guidelines for the management of hypertrophic cardiomyopathy include strain echocardiography for evaluating longitudinal function in early disease. The other condition is cardiac amyloidosis, and in cardiac amyloidosis, longitudinal strain is not only gives you the prognosis, but also is important from diagnostic point of view. Global longitudinal strain is reduced in patients with cardiac amyloid, but there is apical sparing, and which is called cherry red on the top, or sparing of the apical sparing. Then we can use the myocardial strain in valvular heart disease, although it's still not in the guidelines, but maybe it may come in the future in the guideline. And then come to the myocardial strain in HFpEF, and this is another condition where we can use the myocardial strain and global longitudinal strain, very promising method to identify patients with mild systolic dysfunction, which is not reflected in reduced EF. Another condition is hypertension. I think next session is on hypertension. So speckle tracking echocardiography can identify subtle adaptive changes of LV systolic mechanics in hypertensive patients. Then come to the patients with ischemia. We can use the myocardial strain to diagnose ischemia, especially while doing the stress echo. Then come to the left atrial strain. Left atrial strain is also important because it actually signifies the presence of increased filling pressures, or it correlates with the LV diastolic dysfunction. And speckle tracking echocardiography has proven to be useful and applicable in the assessment of left atrial function. Left atrial function is divided into reservoir, conduit, and contraction phase. So these are the three types of strains of LA strain, and these are the different values for these strains. And the reservoir strain, also referred as peak atrial longitudinal strain, it is considered the most important due to its prognostic value in cardiovascular disease. Both LA reservoir and contraction or pump strains measured by speckle tracking echocardiography are markers of LV filling pressures, and they have good correlation with the diastolic function. Thank you very much.
Dr. Tipu, can you just stand there for a minute? How would you rate MAPC in those machines where you don't have the strain imaging?
Okay, MAPC is a good parameter and it has a good correlation because it indicates the longitudinal LV function. So it has a good correlation with longitudinal strain, but sir, there are different, number of limitations of MAPC as well. If there is, regional wall motion abnormality involving the basal area, then it would be reduced, and if there is, mitral annular calcification, it would be reduced. But it's an easy way, and if you don't have the strain, you can use MAPC as a good parameter for assessment of longitudinal LV function with the, limitations in your mind.
So it is reasonable to call it the poor man's
yeah, you can
strain.
But I think, sir, अब ये वो वाला ज़माना है जहाँ पर टावी हो रहे हैं, तो फिर मेरा ख्याल में एक स्ट्रेन अगर एको की इमेज में हो जाएगा तो कोई बड़ी बात नहीं होगी.
बिल्कुल
ठीक है. Thank you.
Thank you, Dr. Tipu, for your brief and crisp talk and for right in time. We will conclude this session with the experts' opinion if they want to have some. We will conclude this session with the panelists' expert opinion. I think we are running short of time and we should move forward with the next session. Thank you very much for this session.
Bismillahirrahmanirrahim. I'm Dr. Abid Saeed and I'm going to moderate the session which is on hypertension. And without any further delay, I would like to invite the panelists that they should come on stage, please. Dr. Sayyid Nasir Shah Sahab, please come on stage. Dr. Asadullah Bukti, Dr. Muhammad Ishaq, Dr. Charag, Dr. Imran Fazal, Dr. Qazi Abdul Sabur, Dr. Nawaz Lashari Sahib, and Dr. Khabar Abbasi Kazmi. We have four sessions on this hypertension session. The first one is the Dr. Naeem Aslam, and the topic of the presentation is the latest guidelines in the management of hypertension. I would like to ask Dr. Naeem Aslam that to please come on stage.
Thank you very much. So thank you very much for the invitation, and we are too late. Then anyway, we will start the topic, and it is the current updates. And Dr. Saib Naeem will continue on this session.
Assalamu alaikum. Thank you for the opportunity. I will start the presentation without any delay. Bismillahirrahmanirrahim. My topic for today is latest trend in hypertension management, what ESC 24 guidelines tells us. So it will be basically focused on what are the changes that have been made since 2018 ESC guidelines on hypertension. This guidelines that were published in 2024 had 136 recommendations, out of which 57 were the new recommendations. And these are the few categories in which recommendations have been changed. Measuring BP, definition, classification, diagnosis, preventing and treating, management of specific age group, patient groups, and patient-centered care. What was the reason to bring about the new guidelines? This was the reason, as hypertension is the leading cause of morbidity and mortality in worldwide, and it is the top-ranking cardiovascular modifiable risk factors. And astonishing is it was the top ranking in 1990, and it has maintained its top position till 2019. Inter-Aspire study was published in 2024, which was aimed to see the targets achieved by, as set by the guidelines, and for secondary prevention of cardiovascular disease. And unfortunately, 61% of the patients in this study were not having adequate blood pressure control. This is another reason that every 10 mmHg rise in systolic blood pressure, there is the doubling of CVD hazard ratio. This is an interesting story of the guidelines of hypertension. It was in 1984 when JNC3 was published, the threshold for hypertension was 160 systolic and 95 diastolic, which was later changed in 1993 when JNC5 was published to 140 systolic and more than 90 diastolic. And up till now, till 2024, these guidelines and these were the thresholds which were being followed. These are few studies which favored the more intensive control of blood pressure over less intensive control. Major CVD events were reduced with intensive control. This was with 120 versus 140 mmHg control, and this was with 130 versus less than 130 versus more than 130 control. So this was the previous guidelines in which there were 7 categories, lot of hassle and difficult to apply in the clinical scenarios. Now in 2024, ESC has categorized the blood pressure into 3 categories: non-elevated, elevated and hypertension. So simply, if it is less than 120 by 70, it is non-elevated, and if it is more than 140 by 90, it is hypertension. In between is the elevated. There are the two categories. First and last, there is no need of calculation of the cardiovascular risk, as in first non-elevated, there is no sufficient evidence confirming the safety of BP with pharmacological treatment. In hypertension, it is on its own is a significant cardiovascular risk factor. So we are left with elevated blood pressure where we have to calculate the cardiovascular risk. These are the guidelines that differentiate between the out-of-office and in-office blood pressure measuring for the diagnosis of the 3 categories. As I have already said, my presentation, my talk will be more focused on what has changed. So this is the one thing that has changed is in 2018, it was out-of-office BP measurements, if logistically and economically feasible, was a third point, and now they have given more emphasis on if not logistically possible, if not logistically and economically feasible, repeated office measurements should be taken. Otherwise, the gold standard for diagnosis of hypertension is out-of-office BP measurements. Another thing that has changed in diagnosing the hypertension is echo. Initially in 2018, the criteria for echo in patients with hypertension was ECG abnormalities, signs and symptoms of LV dysfunction. Now they have journalized it to ECG abnormalities and signs and symptoms of any cardiac disease, and you have to go for the echo. So this is almost basically the same thing. This is the protocol for blood pressure measurement in office. Patient should be seated, the validated device, a cuff at the level of heart, 3 times, take 2 average, obtain 2 further readings if more than 10 mmHg difference in the previous readings. Both arms can apne lena hand, record heart rate, also check for the orthostatic hypertension for first visit. Then there was a change in coronary risk evaluation in 2018. Score system was the criteria to risk stratify the patients for cardiovascular disease, and it was for the hypertensive patients, and it was not to be applied on the patients who are having already established cardiovascular disease, CKD, elevated single risk factors or hypertensive LVH. Now they have changed it to score 2 score risk stratification score, and it is for the patients of age 40 to 69 with elevated BP, not hypertensive. So this is the one thing that has changed, and the other thing that has changed is that they have added the hypertension mediated organ damage into the category where you don't have to risk stratify the patient, you have to straight away go for the pharmacological therapy. And score 2 was introduced, which was for older people. Score 2 OP is for older people, for patients aging more than 70 years. This is basically all the same we have already talked about. So in terms of lifestyle modification, almost all the recommendations are the same and are being brought forward in the same guidelines, in the guidelines of 2024, except for this one. They have all added an alternative method for uh, exercise. It is 75 minutes of vigorous intensity exercise over 3 days, complemented with moderate intensity dynamic or isometric resistance training. The other thing that is changed is in 2018 there was advice of restriction of alcohol consumption to less than 14 units in men and less than 8 for women, which in these guidelines have changed to it is recommended to avoid alcohol altogether. So another change that has occurred in the lifestyle modification is increased potassium intake, or you can say supplementation of the sodium with potassium intake. This we have already talked about. Caveats in the lifestyle modification: in uncontrolled hypertension with patients excessively high BP, you should be very cautious in prescribing the exercise, as it can be having deleterious effects. And association between potassium intake and systolic BP and CVD events may be sex specific, more stronger in women. And there is a contradiction with the CKD guidelines, which recommend a restriction of dietary sodium to less than 2.4 gram per day in advanced CKD. And the evidence for replacement of sodium with potassium was that these two trials, SASS and DECIDE SALT trials, in which sodium potassium urinary excretion ratio was resulted in reduction in systolic and diastolic BP. So blood pressure targets in 2018, it was first lower the BP to less than 140/90, and then you have to target it to less than 130/80, and the age for elderly was more than or equal to 65. Now it has changed to you have to treat the patient to 120/129, and elderly is 85, and ongoing treatment for lower thresholds is for pre-treatment symptomatic orthostatic hypertension, age more than 85, moderate to severe virility, that means virility index of more than 5, and limited predicted lifespan. These are the risk modifiers which you can apply, and where you cannot risk stratify the patient with scoring system, as for young adults, in patients with score less than. So in the end, hypertension guidelines have been changed in pregnancy. इसके अंदर भी आपका 140 जो है उसको अब chronic hypertension को उसको ऐड कर दिया है. So in conclusion, this is the conclusion slide. New definition add हुई है, that is office systolic BP 130 और hypertension के लिए 140. Out of office BP measurements are recommended. Risk assessments for the elevated BP, and lifestyle and pharmacological treatment for CVD risk more than 10%. New lifestyle recommendation, we have already discussed potassium supplementation and implementation of the guidelines. That's it.
Well done. Thank you very much.
Thank you, Dr. Soeb, for refreshing the guidelines about the hypertension. We have little shuffled the presentation schedule because Professor Haroon has to leave earlier. So I would like to request Professor Haroon to talk about the management of resistant hypertension. Sir.
Assalamu alaikum. Bismillahirrahmanirrahim. So we have got a very interesting topic in hypertension, and I think most of you will be
hypertensive by now,
putting up your intake and your own experiences as well. Well, as we are all aware that what is resistant hypertension? Characterized by blood pressure that remains above target despite adherence to at least 3 antihypertensive agents of different classes, including a diuretic at optimal doses. And even in some of the references, you can find that they have included an angiotensin receptor blocker or an angiotensin blocker. The first one is angiotensin receptor blocker plus calcium channel blocker plus a diuretic. So at least these 3 drugs should be on the menu And in spite of that, if they are taken to the optimal doses, the patient's blood pressure is not controlled, then that's where we call it resisted hypertension. There is another heading with the refractory hypertension. That is one which is slightly different from the resistant hypertension. And resistant hypertension is a part of refractory, or refractory is a part of resistant, you can say. But in the refractory, basically, we come across 5 drugs. Somebody is taking 5 drugs, and then it may or not be able to control that. Then we call it a refractory hypertension. So the prevalence when we see our patients is around 10 to 20% of the hypertensive patients we come across with resistant hypertension. The clinical significance associated with increased risk of cardiovascular events, renal dysfunction, and mortality. The first line, this is the 2024 ESC guidelines key updates. First line pharmacotherapy, spironolactone recommended as the preferred add-on agent for resistant hypertension unless contraindicated. And of course, renal denervation therapy, about 1 or 2 decades back, it was in vogue, but then it was found not to be very much preferable or very much having any good results to treat resistant hypertension, so it went away. But again, now it's back. So I will not go into the details of renal denervation because it is a separate topic in itself. So considered for patients with uncontrolled BP despite a 3-drug regimen, including diuretics, suitable for patients with an estimated GFR of more than 40. Require performance in experimental centers following a shared decision-making process. So the American Heart Association and International Society of Hypertension perspectives are, of course, as for any other type of hypertension, lifestyle modifications, emphasis on dietary changes, regular physical activity, weight management, and sodium reduction. And of course, the pharmacological strategy is similar to ESC with spironolactone as a key add-on agent. Then device-based, as already I have mentioned before. So this is the Mayo Clinic Insights Comprehensive Evaluation. Assessment for secondary causes of hypertension, utilization for ambulatory BP monitoring to confirm true resistance. Because we come across a lot of pseudo-hypertensive patients as well, patients not adhering to the drugs, and so on and on. Multidisciplinary approach, collaboration among cardiologists, nephrologists, endocrinologists for individualized patient care plans. Some of the emerging pharmacological therapies will be of interest to you. These are under investigations, but one of the drugs by the name of aprocitentan has been approved by the FDA in last year, March. And the mechanism of action is dual endothelin receptor antagonist. It is dual endothelin receptor antagonist. Both endothelin A and B receptors, it is used for that. And the status approved. Aprocitentan is a very interesting drug, and if, as you must be aware, that endothelin 1 acts on endothelin A and B receptors. And this is the drug which actually stops its action on the A and B receptors. And that is where it leads to vasodilatation, and it leads to anti-fibrotic proliferation, and all these effects are there all throughout the body. And there are, as you know, there are endothelin receptors are everywhere, wherever the blood vessels are, and they are even in the heart, myocytes, they are in the lungs, they are in cells as well, blood cells as well. Another drug to be mentioned is zilebesiran, and this is a small interfering RNA targeting hepatic angiotensinogen synthesis. Administration is by subcutaneous injection, and this is also, especially at the moment, in trial phases. So this is what I was talking about, aprocitentan, and it has been approved. But the side effects, of course, you should be aware that it is contraindicated in pregnancy and breastfeeding. Other emerging pharmacotherapies are there. Baxdrostat, this is an aldosterone synthase inhibitor. Lorundrostat, it is a selective aldosterone synthase inhibitor. Again, it is in clinical trials. Ocedurenone, it is a non-steroidal mineralocorticoid receptor antagonist, like the one we are using nowadays, finerenone. And then there are others as well. So the innovative non-pharmacological innovation targeted thermal therapies and another new outstanding therapy which is coming up. Treatment for hypertension due to primary hyperaldosteronism. Minimally invasive ablation of adrenal gland nodule using thermal energy. Clinical trials early studies show significant BP reduction and potential cure in selected patients. Comprehensive management approach confirm the diagnosis, rule out pseudo-hypertension, pseudo-resistance, white coat effect, non-adherence, assess for secondary hypertension causes, optimize lifestyle interventions, pharmacological optimization is a must, ensure use of appropriate drug combination at optimal doses. Consider device-based therapy, evaluate suitability for renal denervation therapy. Future directions, genetic and biomarker profiling to tailor therapy, long-term outcomes, ongoing studies to assess cardiovascular and renal outcomes with new therapies, as already I have mentioned. Integration of technology, use of digital health tools for monitoring and adherence support. So this is the conclusion.
Thank you, sir.
Resistant hypertension remains a complex clinical challenge requiring multifaceted approach. Recent guidelines and emerging therapies offer new avenues for effective management. Continued research and individualized care are essential to improve patient outcomes. Thank you very much.
We don't need resistant speakers.
Thank you very much, sir, for such a wonderful presentation. We will have a question and answer session at the end, sir. I would like to request now Dr. Kashif Hashmi. He is also the president of Pakistan Hypertension League, and his presentation is about the past, present, and future of hypertension. And I'm sorry that your presentation is a little late from your regular time.
Arun? पैसे पूरे करके जाओ.
बिस्मिल्लाहिर्रहमानिर्रहीम. सबसे पहले तो मैं शुक्रगुजार हूँ ऑर्गेनाइजर्स का मुझे बुलाने के लिए, स्पेशली प्रोफेसर अख्तर अली बंदे शाह साहब का जिन्होंने मुझे ये टॉपिक दिया. वेरी इंटरेस्टिंग टॉक, प्रेजेंट, पास्ट एंड फ्यूचर ऑफ हाइपरटेंशन. मैं कहा ये टाइम शामिल नहीं हो रहा. So this is basically as such not a lecture, just an overview what the hypertension in the past, what in the present now, and what we expect in the future. There is no disclosure as such. Being the second last speaker, प्रोबेबली जो ना इसमें दो फ़ायदे हैं. एक ये कि जो ना वो ऑलमोस्ट एवरीथिंग ऑलरेडी बीन डिस्कस, तो जस्ट हैव टू ओवरव्यू इट. सेकंड जो थोड़ा सा नुकसान है वो ये कि तमाम लोग जो ना ऑलरेडी जो ना वो बहुत ज़्यादा वो चुके होते हैं पूरा दिन सुनने के बाद. तो देयर इज़ नो डिस्क्लोजर ऑफ इंटरेस्ट एज सच, just a picture of the Multan city from where I belong, and this is my institute where I am working. So these are the 4 different ways we can define the hypertension. Not going into their definition, just to look at it, these are the 4 different ways we can define the hypertension. This is I copied from a BMJ editorial. It is not the strongest of the species that survive, not the most intelligent that survive. It is the one that is most adaptable to change. That is what we talk about the evidence-based medicine. अगर आप देखें और से तो लास्ट आप देखेंगे कि ना आफ्टर एवरी 2 or 3 decades आपकी डिजीज़ की अंडरस्टैंडिंग भी चेंज हो जाती है, द मोड ऑफ ट्रीटमेंट बिंग चेंज. और फिर कुरान में आता है कि बेशक बीमारी भी हमने उतारी है और शिफा भी हमने उतारी है. और वो टाइम जब आप शफा तक पहुँचने में लगाते हैं, दैट इज़ द टाइम वेयर द डिजीज़ प्रिवेल. अगर आप टेंशन की प्रेजेंट छोड़ें पास्ट की बात करें तो ये आज की बात नहीं है. 2000 साल से हमें पता है कि जो ना ब्लड प्रेशर जो है ब्लड इज इन द बॉडी एंड इट सर्कुलेट विद सम प्रेशर. बट द मॉडर्न हिस्ट्री स्टार्ट विद द बुक फ्रॉम विलियम हार्वे, वी जस्ट rapidly going through it. Then the hypertension as a description come from Thomas Young 1808, and then 1896 the sphygmometer introduced by Riva Rocky, and then Nikoli Kotokovs described the sounds, the techniques, and then you know, this is a very important statement. We look into it. 1931, John Hay, professor of medicine at Liverpool University, wrote that there is some truth in the saying that the greatest danger to a man with a high blood pressure lies in the discovery, because then some fool is certain to try and reduce it. So at present we all fools are over here and we are trying to treat it. If just go through the different statement by the at that time the जो उस वक्त के अहम लोग थे जिन्होंने ये बातें की, just look into it. And then in 1949, बहुत पुरानी बात नहीं है, कंसेप्ट ये था कि 210 और 100 भी बहुत बुरा नहीं है, इसको ट्रीट करने की शायद ज़रूरत नहीं है. एंड देन यू कैन लुक इनटू इट. द JNC 1977 से शुरू हुई, एंड विद एवरी JNC यू सी के जो ना डिस्क्रिप्शन बीइंग चेंज एंड द वे टू ट्रीट बीइंग चेंज. एंड देन वी हैव डिफरेंट organization giving guidelines. We have AHA, ACC, ASH and different available. And then Pakistan Hypertension League in 2023, the last guidelines from Pakistan Hypertension League for the patient in Pakistan, how it been treated. Because topic is present, past and future of hypertension, Pakistan Hypertension League being founded in June 1997 in Karachi, affiliated with Hypertension League, and this is, you see, in the first available data from Pakistan, जो 1998 में through PHL ही print हुआ, and the hypertension control at that time was only 3% in Pakistan. This is data from my city. Last year में we come across 230,000 patients जो different medical units में आए in cardiology, nephrology and neurology, which presented primarily because of hypertension causing that complications. गाइडलाइंस ऑलरेडी डिस्कस हो चुकी हैं. ये लगाने का मकसद सिर्फ ये था, ये दिखाने के लिए कि जो ना वो पहले कंसेप्ट क्या था ब्लड प्रेशर ट्रीट करने का और अब क्या आ गया व्हेन वी आर ट्रीटिंग 120/70, ये भी जो है ज़्यादा है, इससे भी कम होना चाहिए. सो करंट अंडरस्टैंडिंग हमारी क्या है कि इट्स अ कम्प्लेक्स इंटरप्ले ऑफ डिफरेंट फैक्टर्स. टाइम कम है, इसको हम डिस्कस नहीं कर सकते. एंड वाई वी आर ट्रीटिंग हाइपरटेंशन बिकॉज इट इफेक्ट द आइज, इफेक्ट द हार्ट, इफेक्ट द किडनीज, ब्रेन एंड द माइक्रोसर्कुलेशन. दीज आर द कॉम्प्लिकेशन जिनको हम मरीज़ को इससे बचाने के लिए हम ब्लड प्रेशर को ट्रीट कर रहे हैं आजकल. तो दिस इज़ जस्ट टू कंपेयर विद दैट कि 210 110 जो है वो बुरा नहीं समझा जाता था, और अब वी आर टॉकिंग अबाउट लेस देन 120/70 जो ऑप्टिमल हम कहते हैं कि अब होना चाहिए. दिस इज़ जस्ट टू शेयर विद यू. दिस ईयर वर्ल्ड हाइपरटेंशन लीग अवॉर्डेड पाकिस्तान हाइपरटेंशन लीग एज अ बेस्ट ऑर्गेनाइजेशनल अवार्ड इन अ ग्लोबल कंट्रोल ऑफ हाइपरटेंशन. और पाकिस्तान हाइपरटेंशन लीग को दिस इज़ फर्स्ट टाइम, लास्ट 4 years से मिल रहा है, लेकिन दैट वाज द इंडिविजुअल एक्सीलेंस अवार्ड. दिस टाइम एज अ ऑर्गेनाइजेशनल एक्सीलेंस अवार्ड जो है वो पाकिस्तान हाइपरटेंशन लीग को अवार्ड किया है वर्ल्ड हाइपरटेंशन लीग ने विद 85 मेंबर कंट्रीज. तो दिस इज़ वेरी इंपॉर्टेंट टू शेयर विद ऑल ऑफ यू कि एट वेयर इंटरनेशनली वी स्टैंड. जस्ट टू बी अवेयर, जब हम प्रेजेंट और पास की बात कर रहे हैं तो दीज आर यू कैन सी प्रोफेसर फारूकी, द फाउंडर प्रेसिडेंट, एंड प्रोफेसर इसाक, द फाउंडर जनरल सेक्रेटरी, सिटिंग विद अस. Professor Nazeem Iman, and Professor Shakun Malik. These are the 4 which are still with us, and we still take advices from them. And then we have 3 members which will lose, Professor Maqbool Jafri, Professor Jaz Vora, and Professor Kalimuddin Aziz. The 2 most recently, Allah उनकी मग़फ़रत फरमाए. And I want कि जो ना at the end of this session जो है ना हम दुआ मग़फ़रत भी हम कर लें, because recently we lost Professor Kalimuddin Aziz and Professor Jaz Vora. तो इस सेशन में क्योंकि ऑपरेशन पे हो रहा है तो हम प्रेजेंट और पास्ट की बात कर रहे हैं, तो शुड बी आफ्टर दिस सेशन आई थिंक कि जो ना एक दुआ मग़फ़रत भी होनी चाहिए इनके लिए. हम प्रेजेंट की बात करें, पास्ट की बात करें, फ्यूचर की बात करें, कुछ चीज़ें साथ रहेंगी ब्लड प्रेशर के हवाले से कि आपने मरीज़ को जो ना कंप्रीहेंसिवली एडवाइस करना है लाइफस्टाइल के बारे में, सॉल्ट इनटेक के बारे में, रेगुलर एक्सरसाइज के बारे में. एंड देन मोस्ट इम्पॉर्टेंट, चाहे हम प्रेजेंट की बात करें, पास्ट की बात करें या फ्यूचर की बात करें, पीपल डोंट केयर हाउ मच यू नो अनटिल दे नो हाउ मच यू केयर. और आपके मरीजों की आपके बारे में राय क्या होनी चाहिए? दे लिसन, लाइक माई इनपुट, आई फील सो मच बेटर, दे डोंट आर्ग्यू विद मी, रिस्पेक्ट मी एज अ पर्सन. दैट इज़ रियली रियली इंपॉर्टेंट टू मी. दे आर इंटरेस्टेड इन मी. आपके मरीजों की राय आपके बारे में ये है तो आपका मरीज़ ठीक भी होगा और आप भी जो है अपने ना सिर्फ ये दुनिया भी कमाएंगे, आगे आखिरत भी कमाएंगे. तो टू एंड, this is the present treating hypertension, remember ALARA as low as reasonably achievable. तो हम करंट की बात करें तो एट प्रेजेंट जो हाइपरटेंशन कंट्रोल है पाकिस्तान में, दिस इज 11 to 14%. जो पहला डाटा हमारे पास आया था इन द पास्ट दैट वाज 3%. एट करेंटली 44% ऑफ द पॉपुलेशन being diagnosed with hypertension, 35% being treated, and only 11% at control. In future, we expect some much better than this one. Thank you very much.
And thank you very much, Dr. Kashif Hashmi, for giving us the view about the past, present, and future of hypertension. The last but not the least speaker for today's presentation, that is the renal denervation from myth to reality, will be presented by Dr. Abdul Rauf. Sir, please.
Bismillah ar-Rahman ar-Rahim. So I have no conflict of interest. That will be my outlines. We all know that the afferent and efferent arteries have effect on hypertension, and they increase the hypertension mediated organ damage. There's a lot of 15 years, there are different trials, sham control and non-sham control, which lead to the renal denervation. Consensus by EAPCI with class 2A guidelines that an adult patient with uncontrolled resistant hypertension already being discussed with 140 and 90 millimeter Hg, which is confirmed by the ambulatory BP, and treated with 3 or more than 3 antihypertensive drugs, and the EGFR is 40 or more than 40 ml per liter. This is class 2A recommendation for renal nerve denervation. There are some class 2B recommendation when the patient can't tolerate the drugs, and those who prefer to be treated by RDN by shared decision making, and even if these patients are less than 3 drugs. Now, all these indications being proved by almost all of the societies worldwide. So if we remember the indications, the RDN, the resistance, the hypertension mediated organ damage in the non-adherent patients. So there are 3 types of renal denervations. One is spiral multi-electrode catheters, the Paradise focus ultrasound renal denervations, and the alcohol mediated renal denervation system. So nowadays, which is recommended is the radio frequency renal denervations being manufactured by many of the companies, but the simplicity trial being conducted by Medtronic. They have generators, they have the electrodes, and there's basically from the femoral root. So these were the comparison of the 3 renal denervations, and we can see that the frequency have long and short-term safety as well as efficacy. So before going for the procedure, imaging is important. Which imaging, CT or MR? So they've prepared the CT because to exclude the secondary causes, and for procedure planning by the accessory arteries, devices, angulation, all these things. CTA is important to measures and to look for the accessory arteries. And abdominal aortogram is the gold standard. So how you perform and where it should be taken and why. So it basically is very simple, 5 to 6 French pigtail catheter by the simple 0.035 wires and 10 to 20 cc of contrast. The views will be 1 to 2 lumbar vertebra, APR, LAO 10-20 views. Why? For renal arteries and accessory arteries. For its size, take-up, course, tortuosity, and all these things should be taken in consideration while doing abdominal angiography. You have to selectively take the renal angiogram to look for the size, take-up, course, and tortuosity. That's how you plan for ablation and procedure-related concerns will be taken. If you look into this, this is of the same patient. You can see 3 of the different arteries of the same kidney. They are accessory arteries. So when you do the renal denervation, you have to look for the accessory arteries. If you didn't ablate all the arteries, it is unsuccessful procedure. It is very simple. The procedure is very simple. You assess the renal anatomy. Then if the patient is treatable, then give medication for conscious sedations. Plan your treatment areas and insert the guide wire, advanced simplicity spiral catheter and deploy it. Treat distal to proximal, starting with the branches followed by main renal arteries. And once the one-sided artery done, go to the other artery and treat it. We can treat 3 to 8 millimeter of renal arteries, and for main renal arteries, there is usually 2 to 3 emissions, and for accessory arteries, only 1 emissions. But you have to remember that you have to keep the catheter 5 millimeter if there is stenting, if there is bifurcations, and if the artery is less than 3 millimeters. This is the generator, that how it performs, and you can select any of the electrode or 4 of the electrodes while denervating the renal artery. Some of the side branches are tortuous and angulation. It's very simple, like you are doing the coronary artery, so you have to proper guide wire selections. The body wire can be used, workhorse wire, and then exchange with dedicated wires. And sometimes the ancillary devices like microcatheter and guideliners can be used for the tortuous arteries and angulation. If we talk about the major adverse events, this is the safest procedure. You can see there the 30 days events. Is no significant events occurred in the simplicity trials. Now coming into the conclusion, renal denervation is a relatively straightforward procedure. It's not only safe but also effective. Based on high hypertension prevalence, in futures RDN number will be overwhelming for catheterization laboratories, and RDN should be performed as a day case procedure. It is important to adequately plan for indicated patient and prevent complications. We are about to start the procedure next month, inshallah. All the patients have been screened for that, and we are planning to do 5 cases in Pakistan that we done the
औसत कैथेटर जो
Sir,
प्राइस होगी
there's that question I asked in during
ये
my
आपकी बात
training.
सही है, वो जो स्पाइरल कैथेटर यूज करते हैं, स्पाइरल कैथेटर एफए में यूज करते हैं, इट्स सेम लाइक दैट. If you remove the wire, it's become flexible and attach the valves and then give the thread frequency.
जो स्पाइरल है ना सर वो तो डायग्नोस्टिक है, ये एक्चुअली एब्लेट करेंगे, तो एब्लेशन का जो कैथेटर है ना वो सॉलिड टिप है, उसकी मेरा ख्याल है कि औसत प्राइस तकरीबन 2 और 3.
ये जो कैथेटर है ये भी स्पाइरल सॉफ्ट है और मल्टीपल है.
Yes.
जैसे आप वायर निकालते हैं तो टच करता है.
कैथेटर तो सॉफ्ट ही होगा पर टिप उसकी सॉलिड होगी.
क्योंकि ये टिप पे नहीं रहे, इसके जो मल्टीपल लेवल पे रेडियो फ्रीक्वेंसी
For
अच्छा ये शेप में स्पाइरल होगा,
शेप स्पाइरल है,
शेप में स्पाइरल हो सकता है.
इनका जो ओरिजिनल था वो तो फेल हो गया था जो पहले
हो सकता है, पॉसिबल.
Anyhow, thank you very much for introducing a new device.
Excuse me, Dr. Ali. ये रीनल डिनरेशन आज की तो नहीं है, ये तो आज से 10-15 साल पहले भी आई थी, तो बीच में ये क्यों, why was it stopped? क्या रिजल्ट सही नहीं थे या क्या, what was it?
नहीं सर, बेसिकली शुरुआत तो 2010 से है, तो इसमें डिफरेंट ट्रायल्स थे, फिर कुछ शैम कंट्रोल ट्रायल थे, कुछ नॉन शैम कंट्रोल ट्रायल थे. फिर इसमें पहले अल्कोहलिक वो थी, तो अल्कोहलिक में कॉम्प्लिकेशन ज़्यादा थी. फिर बैलून्स वाली आई, जब सिंप्लिसिटी वालों ने जो अपनी कैथेटर बनाया तो पहला वो नॉन इन्फीरियरिटी था, सो वो उसमें कोई पॉजिटिव रिजल्ट्स नहीं थे. फिर उन लोगों ने 3 इयर्स के लिए प्रोलॉन्ग टाइम के लिए उसको, बेसिकली इसको कंसेप्ट ये है कि जो फेट टिश्यूज है.
नहीं, मैं ये पूछना चाहता हूँ कि पहले रेडियो फ्रीक्वेंसी एब्लेशन नहीं थी, ये अब आई है या पहले भी थी?
पहले भी थी लेकिन रिकमेंडेड नहीं थी, इस पे ट्रायल्स जारी थे. ऑल द थिंग्स हैज बीन डन ऑन ट्रायल बेसिस. अभी तो ये
इसमें जो है ना सर, वो कैथेटर जो था ना पहले स्पाइरल कैथेटर जो अभी जो आया है ना, दैट्स वन नॉट, उसमें टिप पे करंट देते थे उस पे, और 1 or 2 पॉइंट्स होती थी, दैट्स वाई नॉट इफेक्टिव. और अभी भी जो है ना इसका 20-30% डिक्रीज कर लेता है विद न्यू डिवाइसेस.
आई थिंक आई टोटली एग्री.
ये जो कैथेटर रिलेटेड इश्यूज था, अभी जो है ना उसका मल्टीपल पॉइंट्स.
ये बात लॉजिकल है सर कि वो जब वो स्पाइरल शक्ल में आता है और मल्टी इलेक्ट्रोड हो तो एनर्जी मल्टीपल लेवल से डिलीवर होगी, तो सरकमफ्रेंशियल एनर्जी डिलीवर होगी. ये पॉसिबल.
जो पहले
Thank you very much. Any comments from the audience regarding the hypertension?
नहीं, इसका आई थिंक जो पहले हमारे ट्रायल थे, सिंप्लिसिटी के साथ ट्रायल थे, ट्रायल ऑन इट्स ओन पॉजिटिव थे एंड इट स्टार्टेड इन प्रैक्टिस, जनरल प्रैक्टिस में यूज होना था. वी यूज्ड इट इन पाकिस्तान आल्सो, बट फिर एक शैम कंट्रोल ट्रायल हुआ था जो यूएस में हुआ था, एंड दैट ट्रायल वाज नेगेटिव, जिसकी वजह से ये विड्रॉ हो गया उसमें. And the reason, one of the reason they thought was because आप टिप पे से आप करते थे तो आप टिप फ्लेक्सिबल होती थी, तो आप उसको मोड़ मोड़ के करते थे, तो एडिक्वेट जो रीनल डिनर्वेशन नहीं होती थी, जिसकी वजह से ये ख्याल था कि ये है. तो देन दे मेड अ न्यू कैथेटर एंड उनके साथ जो उसके ट्रायल आए हैं, दे आर वेरी प्रॉमिसिंग. दैट्स व्हाई नाउ इट इज अप्रूव्ड एंड बीइंग यूज्ड इन द, बिकॉज यू गेट जी.
So मीर तक मीर says that उल्टी हो गई सब तदबीरें, कुछ ना दवा ने काम किया, देखा इस बीमारी ये दिल ने आखिर काम तमाम किया.
अभी तमाम नहीं हुआ.
ये बीमारी इससे पहले के काम तमाम करे. We have discussed so much about the treatment options for the different diseases.
Can I just interrupt you for 1 minute or 2 minutes, because Dr. Kashif Hashmi has given a very good lecture about past, present and future. It's very disappointing to know that despite all these efforts, even in the USA, not more than 30% or 40% people are under adequate blood pressure control. Yes. So in future, there's going to be a lot of high technology involved in monitoring blood pressure and treating it, including the smartphones and watches and remote monitoring. And so a number of things are in the pipeline which will be able to optimize the blood pressure control, because unless you have got optimal blood pressure control, you cannot prevent the complications that are attached to it.
Definitely.
So I think future may a lot of technology is going to be involved in addition to the pills.
Definitely, this is a silent killer.
There are softwares available, and there are which are available on the smartphones.
And more
they
use
would
of
record
ambulatory blood pressure monitoring.
Their blood pressure round the clock.
Not only technologies, but recent drugs are coming in.
Drugs you mentioned.
Yeah, they are in the picture.
I think
in the pipeline.
My point here is कि हम US की example देते हैं. Hypertension control में there are countries which are much better than US. US is not a very good healthcare system. Hypertension control के लिए आपको technology से ज़्यादा healthcare system की ज़रूरत है. And we have examples. Scandinavian countries हैं, उनमें health जो hypertension control है is much better. Korea में they have now a control of 80%. लेकिन उसमें आपका ये होता है कि you have to have a primary care, robust primary care healthcare system and provision of cost-effective free medication. Until you will do that, तो US की आप हमें एग्जाम्पल को उसके पीछे जाने की जरूरत नहीं है. इट्स वन ऑफ द वेरी पुअर हेल्थ केयर सिस्टम्स. अगर हमने कोविड में भी देख लिया और उनके आउटकम जो हैं बहुत खराब हैं कंपेयर टू द अदर
वेलफेयर स्टेट ही नहीं है ना. यू टॉक अबाउट द वेलफेयर स्टेट्स जो आप अभी जिक्र कर रहे हैं.
यूके का भी यही हाल है. जहाँ पे फ्री मिलती है आपको मेडिसिन, वहाँ भी कंट्रोल जो है ऑप्टिमल नहीं है. सो आई थिंक द न्यू थिंग्स हैव टू बी एडेड ऑन.
So, sir, we have talked much about the treatment options for different diseases. But in the presence of all of the worthy professors, worthy audience here, I just want to ask one thing, that what is the future of preventive cardiology in Pakistan? Prevention is better than cure. We talk much about the treatment option, but what about the prevention? We have to prevent these diseases. So what is your opinion regarding the prevention of these all bombs, these all atom bombs which are inside our body? How we can control that, we can prevent that?
भाई आखिर में तो वहीं पे आदमी आ जाता है कि परहेज इलाज से बेहतर है.
Yes, definitely.
So ये इस फ्रेज को तो कोई बीट नहीं कर सकता, ना इसको काउंटर कर सकता है. मगर सिर्फ बात ये है कि हमारे अपनी प्रायोरिटीज क्या हैं as clinicians.
So thank you very much, all of the audience. Thank you.
For prevention, yes, and the prevention starts from very young age.
Sir. बिस्मिल्लाहिर्रहमानिर्रहीम. कार्डियोलॉजी एक ऐसा सब्जेक्ट है और बुजुर्ग कार्डियोलॉजिस्ट बैठे हैं कि उनके सामने बोलना और उनकी बातें कार्डियोलॉजी समेटना इज़ वेरी डिफ़िकल्ट, खासकर एक दो दिनों में. और आपके हमारे सामने तो बहुत सारी बुक्स ऑफ कार्डियोलॉजी इस तरह के आप हैं, मोटू साहब है और सो मैंने अदर स्टार्स ऑफ कार्डियोलॉजी. उनके हमारी उम्र जितना इनका एक्सपीरियंस है, लेकिन टाइम की कमी की वजह से हमने इसको समेटना पड़ेगा. रिसेंटली कार्डियोलॉजी के सीनियर कार्डियोलॉजिस्ट का इंतकाल हुआ है, तो उनका मग़फ़िरत के लिए दुआ कर लेते.
डॉक्टर साहब एक यंग कभी हुआ है, डॉक्टर मोइन खान in his 40s died recently, one of our fellows from Tamba and Liaquat faculty at the Liaquat National, Karachi में, अभी last week only.
Last week नहीं. अल्लाह सब मग़फ़िरत कर ले, अल्लाह जो जिंदा है उन पर रहम करे और जो उनका इंतकाल हो गया उनकी मग़फ़िरत नसीब कर ले, उनके दर्जात बुलंद कर ले. हमें अल्लाह इखलास नसीब कर ले कि अपने मरीज़ों का इखलास के साथ इलाज कर सके और ये हमारा इल्म और हमारा जो काविश है ये एक सदक़ा जारिया बने और हमारे दीन और दुनिया दोनों के लिए कामयाबी के रास्ते बने. Okay, this was Silver Jubilee conference, 25th. बेटे सर. तो we have planned कि हमारे जो सीनियर लोग हैं जिन्होंने इस कॉन्फ्रेंस का आगाज़ किया उनके लिए कुछ अवार्ड का बंदोबस्त कर चुके हैं. मैं डॉक्टर निशा को रिक्वेस्ट करूँगा कि वो स्टेज पर आ जाए.
Thank you, sir. Assalamu alaikum and good evening, everyone. I, Dr. Nisha Hamid Awan, resident cardiology at Pakistan Institute of Medical Sciences, will be hosting this session Silver Jubilee Awards. Ladies and gentlemen, what an inspiring and insightful day it has been here at the 25th Annual Cardiology Updates 2025. Now, it's my distinct honor to transition to a truly special part of our program, that is recognizing the persons who are not just shaping our future but actively defining it. These are the relentless researchers and compassionate clinicians whose dedication pushes the boundaries of what's possible in cardiology. First, we must acknowledge the pioneers, the founders of this conference. Their vision, dedication, and tireless efforts laid the foundation of this ceremony. Now, first of all, I would like to invite convener of today's session and this conference, Professor Dr. Akhtar Ali Bundesha, for his reviews.
Bismillahirrahmanirrahim. So we actually finished our scientific program today, and this is the last segment. It will be only for 5 minutes or 10 minutes. The awards which we have, which are basically 25-year excellence participation awards for the clinicians who have been part of this conference, rather who started and have been in this journey so far, a quarter-century journey actually. And this conference could not be possible without the help and support of the pharmaceutical industry, and we have a 25-year excellence participation award for them. For the clinician, it's participation award, and for them it is उनके लिए क्या नाम रखा है हमने जो नहीं जो कंपनी को देना उनको partnership award, so excellence partnership awards. तो मैं रिक्वेस्ट करूँगा प्रेसिडेंट PCS से कि वो आके तो कुछ लफ्ज़ भी बोलें और फिर ये अवार्ड्स दें.
Bhourban, always the favorite place of many of all, and I am glad. Once again, I will say a lot of applause for. He has worked a lot and he was busy, and all the time I saw a smile over his face. So thank you. Thank you. Proceed to the.
और ये जो conference थी, this was started by Professor Mattu, जो मेरे mentor and my supervisor, and he has been a name in cardiologists and cardiology community. He is amongst us, mashallah, healthy, and the first award goes to Professor Afzal Mattu. Please, sir.
Professor Dr. Abid Amin, sir, please come on stage and receive your award. We will deliver them. Okay, sir. Now, Professor Dr. Muhammad Kaisar Khan, sir, please come on stage. Professor Dr. Abdul Samad, sir, please receive your award. Okay. Next. Professor Dr. Afzar, sir, please receive your award. Professor Dr. Afzar Raza. Yes, sir. Dr. Akhtar. Professor Dr. Akhtar Ali Bundesha. Sir. Professor Dr. Amber Ashraf. Professor Dr. Amber Malik. Professor Dr. Asad Akbar Khan. Professor Dr. Asad Riaz Kichlu. Professor Dr. Asad Akbar Khan. Asad Akbar. Asad Salim, Professor Dr. Asad Salim. Professor Dr. Asad Salim. Professor Dr. Ashur Khan. Professor Dr. Asim Javed. Okay. Professor Dr. Bashir Hanif. Professor Dr. Bilal Mohiuddin. Professor Dr. Farhan Tayyab. Professor Dr. Habibur Rahman. Professor Dr. Habibur Rahman. Professor Dr. Hafizullah. Professor Dr. Imran Fazil. Professor Dr. Iqbal Saifullah. Professor Dr. Jalaluddin Achakzai. Professor Dr. Jawad Akbar Sial. Professor Dr. Kashif Hashmi. Professor Dr. Halida Sumro. Professor Dr. Halida Sumro. Professor Dr. Hawer Abbas Kazmi. Professor Dr. Mahmood Al Hassan. Professor Dr. Miqdad Ali Khan. Professor Dr. Miqdad Ali Khan. Professor Dr. MMH Noori. Professor Dr. Muhammad Ayub. Professor Dr. Muhammad Ishaq. Professor Dr. Mujibul Haq.
Congratulations, sir. Thank you.
Professor Dr. Nadeem Kamar. Professor Dr. Nadeem Rizvi. Professor Dr. Naeem Aslam. Professor Dr. Muhammad Naeem Malik. Professor Dr. Nasir Ahmed Samor. Professor Dr. Nawaz Lashari. Professor Dr. Nazir Mamun, Professor Dr. Nusrat Ara Majid, Professor Dr. Qazi Abdul Sabur,
Madam Nusrat.
Professor Dr. Rajkumar Sajdiwani,
ये चैनल फ्रेम पे भी दिया आदमी
Professor Dr. Shehbaz Qureshi, Now, Dr. Hafsa will receive award for late Professor Dr. Shahid Nawaz Malik. Professor Dr. Shahriyar A. Sheikh, Professor Dr. Suhail Aziz, Professor Dr. Tahir Saeed, Professor Dr. Tariq Abbas, Professor Dr. Zubair Akram. Someone please receive award for late Professor Dr. Tahir Iqbal.
इमरान आप ले लें
Now we are going to present Partners Excellence Awards. Professor Dr. Shaukat Malik, he's not here, I think.
There are actually few names missing in the list, but we in the original list they are there. और उसमें शौकत मलिक साहब भी हैं, हारून बाबर साहब भी हैं, शहबाज सरोवर साहब भी थे, टीपू साहब भी थे. We have those awards and we will. हाँ जी, उनको हम वो पहुंचा देंगे. हाँ जी, तो हारून बाबर साहब को दे दें.
Professor Dr. Haroon Babar, sir, please receive the award. Professor Dr. Mansoor, sorry. Professor Dr. Mansoor. Brigadier Azmat Hayat, sir, please come on the stage. Professor Dr. Shaukat Malik. Professor Shaukat Malik. Professor Shehbaz Qureshi is receiving his award. Professor Rashid Khan Sahab, please sir, come on the stage. Sir, now Partners Excellence Awards. ADCO Laboratories, any representative? ADCO Laboratories. CCL Pharma. Digital Imaging. Anybody from Genix Pharma? ये digital Genix Pharma, Gets Pharma, Health Tech,
All those who got the medals, they should come for a group photo.
High Noon Laboratories, HiQ Pharma, Hilton Pharma, Hura Pharma, Hilton Pharma, Hilton. High Noon Laboratories, Horizon Pharma, Indus Pharma, Indus Pharma. Martin Doe Marker, Nabi Qasim Industries, Martin Doe Marker, Nabi Qasim. Missing. Novartis Pakistan, OBS Pakistan, Farmevo, Farmevo. Roche Pakistan, yes. Roche. Varic Pharmaceuticals, Wilson's groups, Artica Biotech, Wilson's, Biotech, Berasmed, IDC, Berasmed, Brosmed है. IDC, Grace Events, PC Bhourban. Arslan will receive this award. Mr. Arslan, please come on stage. This concludes today's session. Thank you so much. Now everyone come on stage for group photo.
कब होना गाला नहीं मैंने किधर आजा आजा साइड
Everyone, please join us for gala dinner. Yes.